everybody, and welcome. My name is Melanie Dizon. I'm the Director of Education and Research at the Davis-Phinney Foundation, and I am here today with Dr. Rodolfo Savica. How are you doing? Thanks so much for joining us.
I'm doing very well, thanks. What about yourself?
Pretty good, pretty good. This is going to be a little bit different than our panel. Thank you, Tom. Hi, Tom. Thanks for being here. This is going to be a little bit different than our normal panel. So we usually have about 7 or 8 of us on, and we pick a topic and we talk about it. Today we have brought on Dr. Savica so we can get a real deep dive into YOPD dementia. I'm going to do a little intro first. So Dr. Savica is a medical doctor and a PhD and is faculty at the Mayo Clinic in Rochester, Minnesota. He focuses on Parkinson's, Lewy body dementia, and early life risk factors. In addition, he's interested in YOPD, dementia, and the role of the late life consequences of head trauma. Thank you so much for being with us today. And then Tom Palizzi is going to be my co-interviewer. Many of you know Tom. You've seen him for many, many months in a row if you've been joining us for our council. Tom is a regular member of the YOPD Council panel. He's one of our Davis-Phinney Foundation ambassadors, and we're going to be tag teaming this interview. So thanks for coming here, Tom.
No problem. Glad to be here.
I'm excited to get started. Dr. Savica, what is YOPD? And do you consider it, is it considered a different disease? Is it different enough than, Parkinson's for people who get it later onset?
Well, that is a very, very articulated and complex question. There are many questions within the same question. I would say the first thing first is that let's go even a step back. You say YOPD, which is totally fine. I'm not going to argue against different nomenclature. But as we all know, you may read young onset Parkinson disease, early onset Parkinson disease, I don't know, any other adjective that you may interact and find. That is a major problem because in the US, not so much. But if you think about it, the way you call a condition, the way you call a disease, fix and change the way regulatory agencies and the way the disease is defined. I give you an example. If I ask around in these 112 people around, participants around here, I ask you guys here in the panel here, say, okay, what is young onset Parkinson disease? When we consider young onset Parkinson disease, at what age? I will have 114 different questions and 103 different answers to the same questions, which is a major problem. Clearly, what we can say is that I will use the term early onset Parkinson disease because I want to time it earlier than the usual onset of Parkinson disease. So it's before the usual onset of Parkinson disease, of the motor symptoms of Parkinson disease, that are usually occurring around 65, 70 years of age. So everything paradoxically, which is before that, can be considered early onset Parkinson disease. In the literature, if you want to use the term young, you can consider somebody 60 and below in terms of onset. In some literature, you go 55 and below to be more conservative. In some other literature, you go 40 and below, but you realize that there's a huge difference between 40 and 65. I'll give you an example. In some countries, and I'm encountering this because we are trying to define the nomenclature, we're trying to harmonize the word to call this condition in one way is a disaster. Trust me, disaster. I'm losing my mind around that. For example, in Australia, they talk about young onset Parkinson disease before the age of 65. So everything, because 65 is the age of retirement in Australia. I don't know whether it's the right choice, but every country is different. We have to consider something different for every country. Biologically, it's different. If we move from a mere nomenclature that we had to do for research or to harmonize the regulatory agency or for funding purpose, because funding is important, research is important, and advocacy is important. But if we move to biology, clearly, late onset Parkinson disease, so something that happened in 65 and 70. Well, the motor onset happened there. Compared to what happens in 50s, 40s, is likely a complete different disease. A complete different biology underlies the two different aspects. The outcome is the same. The outcome is damage of the substantia nigra, damage of the basal ganglia, the areas where dopamine is contained. But what brings this damage in is different. Are different conditions, different diseases, different biology, and different tissues, different organelles. And I use the term organelles on purpose. Organelles, not organs, little or morphofunctional unit of the cell that are involved. I'll give you an example that is very important. Everybody knows in this call, I guess, that the presence of Lewy bodies is the hallmark of Parkinson's disease, right? If you look at the brain of patients that have Parkinson's disease, we see Lewy bodies in different areas of the brain. Well, if we open up the brain of younger patients, you may not see any Lewy bodies at all. This is telling us that the disease is different. You heard also another thing that I say, motor onset, in other words, tremor, rigidity, falls. But we know that in late onset Parkinson's disease, there's a number of symptoms that can precede the motor onset for many years. I'm talking about anosmia, so lack of sense of smell, not acutely like in coronavirus, but more prolonged, constipation, dream enactment behavior disorder, so the tendency to live out the dreams, and many others, depression, anxiety, many others. In early onset Parkinson's disease, in young onset Parkinson's disease, these symptoms are not very common. So patients do not have this long latency of 10, 20 years before the motor symptoms start. Sometimes even the presentation of symptoms is different. And maybe many people in this webinar may have that, may see that, for example, the typical onset, motor onset of Parkinson's disease later in life is presence of tremor, people feel a bit of stiffness, maybe a frozen shoulder, people slow down. You heard that. People tend to fall, probably balance and so forth. Let's go back. If you got in the younger people, one of the most common symptoms is that when people are exercising, they're having contraction, cramps, what we call dystonia, but initially they look like cramp. And so patients are going to the orthopedic doctor and say, you know, I'm running a marathon and around my third hour of run, I have a cramp that is very odd. And every time I run, I had the same problem. So you're thinking you have what? An orthopedic problem. And most of the time, it is indeed the onset. It can be the onset of Parkinson's disease that behaves in a complete different way at the beginning in younger patients compared to later patients. So clearly, we have epidemiological data that support the difference between younger onset, early onset, and late onset. We have biological data that support early onset versus late onset. We have some genetic data. However, I don't want to get there, but it's important to say, not every young onset patient has a strong genetic familiar background. That was the original sin, quote, quote, of the literature, thinking, oh, early onset Parkinson, young onset Parkinson is a genetic disease. It's only present in the family if you have a strong familiar background. Not always the case. Actually, is the opposite. Familiar cases are a little bit less common in terms of genetic frequency compared to the sporadic one. Many people here may have Parkinson and they may not have anyone in their family with Parkinson's disease. So you see, but say, oh my God, but so what do I have? You have early onset Parkinson, but it's not a strong genetic background that we can pinpoint and argue there. So we say epidemiological, biological, genetic, clinical symptoms are different. And when we talk about clinical symptoms, we have to do a step in terms of treatment, management. The management is slightly different. The progression is slightly different. The prognosis is different and depends among many factors. The life expectancy is completely different. And most importantly, and then we can talk more about it, and maybe some of the panelists can talk, the social aspect, the societal aspect, the need of our patients in their 40s, 50s, even early 60s are completely different than the need of our patient in their 70s and 80s and 90s. You have responsibility on your work, on your family, on your kids, on your life. Even if you don't have any of this, but you just want to live your life, you have 40 years ahead of you at least. And it's different than having a condition that is still serious, still to be considered in late 70s or early 80s. So it's a very different, there are two different conditions named the same way. But we have to strongly think and talk about the fact that there are different needs, different understanding, different biology, different data, and different everything, basically. They only just have the name in common.
That's a lot. So
yeah, absolutely.
So really, I mean, basically then if, one of the things we've heard, once you're YOPD, you're always YOPD, because if you were early onset diagnosed, you're going to have, you're even if you're 70, right? Like you were diagnosed when you're 40, you're going to have a different trajectory than somebody who gets.
Absolutely. Yeah. Absolutely. There is an important, this, Mel, if you don't mind, this is an important thing, very important. Now we are seeing patients that have 70s or even 80s and have the disease for 30, 40 years. Who are they? They're still a young onset Parkinson. It doesn't really matter. Aging is something that we don't control. We age every day, right? Unfortunately. But so it doesn't matter. The age when we see the patient, when I see the patient in the clinic, it doesn't matter. I'm interested to know when the motor symptoms started. And please mark my words, when the motor symptoms started. If we are pinpointing the non-motor symptoms, we go way back when, and it's more complex.
Mm-hmm. So YOPD and dementia are not frequently discussed together. Mm-hmm. So what does it look like? Well, first of all, I guess, let's do a relative comparison. What does dementia tend to look like in people with later onset Parkinson's general? And then what does it look like for people that were diagnosed YOPD? So
memory loss and dementia is a very complex phenomenon in the general population, but also especially in people with Parkinson's disease. We have three things that are ongoing in people that have Parkinson's disease. We have three processes: aging, that is increased the risk of all of us in this room to have plaques and tangles of the Alzheimer's disease type. We get older, the plaques build up. We know that. There's little to say. We have in later onset Parkinson's disease the presence of Lewy bodies that are causing a different way of cellular damage that can indeed cause memory loss. And we have vascular changes that are occurring at the same time and causing an additional damage. So when we get older, there are three things that are interplaying and we have to consider every time. If we talk only about one, in this case, just the damage caused by the Lewy bodies, so not about the Alzheimer's disease tangles, not about the vascular changes, I can totally say without further risk that the memory loss that we see in Parkinson's disease is completely different than what we see in Alzheimer's disease. Dementia is a memory loss that is interfering with our activity of daily living when patients may or may not have insight about the problem. And the memory loss that we see in Parkinson's disease, in terms of testing, is a completely different one. It's not necessarily memory, oh, I forget the name, or I'm forgetting where I place things. is mostly have to do with psychomotor slowing. Patients with Parkinson's disease are a bit slower in moving, but also in thinking at times, in planning ahead, in doing multitasking. And sometimes people say, you know, something that was taking me a task or doing two tasks at the same time, it takes me so much longer than before. That is one. The other aspect of the memory that is affected is usually what we call the visual spatial memory. So the ability of having a good depth perception, the ability of seeing our body in the space and understanding our space awareness. This is very different than what we see in Alzheimer's disease, where usually working memory, the short-term memory, is the first, generally speaking, domain to be affected. So we already have a different number of memory problems. And some of these memory problems, especially the planning, that what we call the executive function, may respond to the appropriate treatment, may respond to dopamine. They may respond to carbidopa-levodopa, the gold standard of medication. So even when I see somebody in their 70s or 80s that have Parkinson's disease, they have Parkinson's disease, they come and say, you know, my memory is not good. I say, hold on, let's optimize the treatment with carbidopa-levodopa, with dopamine, and see after the optimization if you still have memory loss. If you still have memory loss, we have to go a different route. But it's possible that your memory loss would improve, the brain fogginess would improve, the feeling of I don't feel that I'm able to get to the speed may improve with the replacement of the treatment of carbidopa-levodopa. But I told you, we're talking about Lewy bodies here. If we adopt this knowledge and we bring it to the young onset group, we are doing a mistake. Because as usual, we cannot use the knowledge that we have in the later onset Parkinson's disease to the younger onset. It's simply wrong. In later onset Parkinson's disease, I can tell you that some memory loss, ranging from mild, very mild, to very severe, is present at about 8 years in about 39% of the people. But again, wide range, from massive dementia to some mild problems. Young onset is not this way. Young onset are usually people, patients, and I tend to say people because I don't care about the idea of patients. So people that are working, are functioning, are still an integral part of the society. So their mental needs are higher. They require way more ability in terms of functioning in everyday, especially in an everyday life when we are constantly bombarded by 20 million stimuli at the same time. The most common symptom of early onset Parkinson's disease is what they call brain fog. In other words, they feel
you got a big smile there, Tom.
Yeah.
no, in a cloud, like it's hard to describe. We don't have words to describe, but brain fog is the most common one. Say, you know, I'm able to do stuff. I do stuff, but it's taking me longer, or I have a little bit more problems to go there. And if you ask me how frequent is a full-blown dementia in early onset Parkinson's disease, I tell you, it's not very common. Not very common. If you ask me, oh, what about 20 years later? Well, 20 years later, you might have Alzheimer's, you know, because you're aging. Or 30 years later, you might have, if you're 80 now, you had Parkinson's for 40 years, you're 80. You may have Alzheimer's on top of your Parkinsonism or your early onset Parkinson. So we have to consider this difference, that the more we get close to a later age, the more there is a risk of Alzheimer's disease, plaque and tangle, and vascular changes that have a major role because we age, all of us. In terms of are there forms of early onset Parkinson that can cause dementia per se? Yeah, there are some when talking about familiarity. If somebody has some genes that are producing too much alpha-synuclein, too much Lewy bodies, then for sure, you may have an earlier onset of memory loss. But if you don't have this gene, if you don't have this cascade of event leading to the accumulation in the brain, we don't see that very much. And we don't see atrophy. We don't see shrinkage of the brain. The brain doesn't shrink that much. I mean, shrinks because we get older. Again, after the age of 25, we're going down. There's nothing we can do. It will just go downhill. Right. There's nothing we can do about it. But that's about it. Dementia, if you ask me, what about dementia Lewy bodies? What about the same condition, dementia Lewy bodies, but Parkinsonism with more memory loss, with more hallucinations? Is there a condition called early onset dementia Lewy bodies? Yes, but it's incredibly rare. To be honest, we are publishing a paper on early onset dementia Lewy bodies, and there's nothing out there. We are among the first that ever published on that. Why? Because it's a condition that is not being very well described. We are talking about a handful of cases, people in their 40s and their 50s. Again, likely they have some genetic predisposition and some environmental effect on the genes, causing an acceleration of these processes, because it's a very unusual presentation of this particular condition.
Okay, well, that's super helpful. Tom, can you tell us a little bit about, you smiled when he said the brain fog. Can you tell us a little bit about that experience for you? And then you can ask your question.
Yes, please.
Yeah, it's a common thing, right? I think all of us with Parkinson's experience that at some time or another, maybe sooner than others and whatever, but we're all kind of different. But the brain fog, really, it is just that. I feel like my head's a puzzle and all the pieces are pulled apart. So it's just really kind of like the doctor's saying, it's hard to describe it. I mean, it's unique. And I hear Davis talk about the brain fog and that. So
is that something that you felt like before? I mean, I remember your diagnosis was fairly quick. I mean, you were like, you went to your doctor, you went, you got your diagnosis, but was that brain fog? Was that something you felt for a while before you got diagnosed?
No, early on, there was very little brain fog. The brain fog developed as time went on. So lately, it's getting to be more, shall I say, visible, if you will, but more there. But early on, I functioned basically normally. So I think that the non-motor symptoms develop just like the motor symptoms. They kind of slowly over time, they get worse and worse as things go. And I think what I suffer from mostly now is memory loss, or my wife will say, I told you we were doing this. And I said, well, when did you tell me that? And the ongoing argument ensues and I usually lose. So, but that makes sense. I mean, I faced, and I understand that. I hear that from my kids too. My son will say, Dad, we talked about this the other day. So it's like, oh, yeah, I really play close attention. So part of a brain fog, part of the memory thing, it all comes to play.
One thing you use a term that I think is crucial: attention. Focusing, attention. This is something, the attention network, which is called the attention network, which is a network that we have to keep us aware about things in the day and is relevant for our memory, is a network that goes in the frontal lobes. It's really in the frontal lobes. And we do know that this network, it's part of the network, requires dopamine to function. So sometimes, I don't say it's your case, Mr. Palizzi, but I say sometimes some patients are reporting that they have a constant memory loss, but when the medication drops, the memory loss is worse. And then when the medication comes back in, having some of the non-motor fluctuations, the memory loss is better. This is valid, for example, for other symptoms such as, anxiety, sometimes depression. Some patients are reporting, not everyone, but reporting that as the medication fluctuates, their mood responds to the fluctuations of the medication, which has to do with the pathway that goes from in the center of the brain to the frontal lobes, and is responsible for this, for the mood and for the memory and for the attention, and can respond to changes in medication. I don't say will necessarily respond, but can respond. One thing that I want to tell that to me is very, very, very important. So there are some medications that are known to worsen slightly the memory. For example, dopamine agonist, Requip, propinerol, roticotin patch, if taken at a high dose, can cause memory problems. Is important to know. But also, and seem to be, again, it's not in everybody, but it's something to consider. Something that, again, is a really relevant point is that people that are using carbidopa, levodopa, cinnamon, one of the reasons at times because they don't function very well, the brain doesn't work, doesn't matter the age, at this point is any age, it's hypotension. So low blood pressure caused by low perfusion in the brain. An hypotension that you don't need to, if you measure the blood pressure, maybe it's around 100, 110. So not necessarily too low. For me, too low is below 90 as a systolic, as a top number. But if I or Mel or whoever is having a blood pressure constantly of 100, 105, our brain, when we have more in demand or more brain activity, will be perfused less. And the lack of perfusion can make us in a brain fog. So again, I don't say it's always the case, but those are the things that can be manageable. Low blood pressure, adjusting the medication, and minimize anything else that can interfere with memory loss.
Great. Somebody said, my wife was diagnosed at age 37 and passed away 5 months ago at age 66. For the last 1.5 years, she had paranoia, but the real problem was paranoia. As a result, she refused to eat. Is this unusual?
Well, we are talking about 30 years later.
Yeah.
In other words, clearly the damage, unfortunately, has been built up through years. I would be very surprised, however possible, but unusual, if you were told that the paranoia was present for 25 years. If it was present for 25 years, maybe the diagnosis should be revised. But at the very last year and a half, when the damage, the accumulation of proteins, the biochemical damage has been built up, some of the areas of the brain that are responsible for hallucinations, for psychosis, can be indeed affected. And that is not uncommon. The paranoia that is being described is she doesn't want to eat, she didn't want to eat, but people may have different ones. People may have problems with thinking that their husband or their wife is an imposter. People may think they have what is called reduplicative paramnesia, when they're seeing multiple houses, thinking that there are multiple houses that is still the same house, but multiple one. People, they have what is called the Othello Syndrome. In other words, if you know Shakespeare, is paranoid jealousy, so excessive jealousy toward a partner. But again, in early onset Parkinson disease, I'm not expecting this earlier. Can happen, but I'm expecting this later on in life. One thing I want to tell you, one of our recent studies shows that the life expectancy, the median survival time from early onset Parkinson disease diagnosis to death, it is 38 years. And it's exactly what this person commented 35 years later. You know, if somebody's diagnosis at 45, the life expectancy is 38 years later, so 86, 84. I don't know the calculation. I'm not good at math, never been. So, but you know, that is an important point that is different than late onset Parkinson disease.
Mm-hmm. Right. Somebody said, can you say more about optimizing medication to work with memory loss? Is it a matter of working with the doctor and doses via trial and error to determine the appropriate dose of medication? And how is it like working? And somebody also said around this, is executive function a form of dementia? Well,
yes. So let me start with the last one. In memory, there are 4 main domains in neuropsychology to explore memory. The 4 domains are executive function, language, visual spatial, and working memory. So language is clearly the ability to understand and talk. Visual spatial memory is ability, as I mentioned before, of space awareness, knowing where you are and understanding the space around you. Executive function is planning And working memory is the ability to recall one thing once you learn. If one of these domains, doesn't matter which one of these domains is down, completely down, you can have a diagnosis of dementia based on the fact that one domain is down. There are some conditions, for example, the primary language disorder, when people are having aphasia, people are not able to speak because the language center has been shrinking down, that they are considered form of dementia, in spite of the fact that the other three domains are basically intact. So it's a matter on how much, to have a diagnosis of clinical diagnosis of dementia, is a matter of how much this problem with the domain involved is interfering with the activity of daily living. If it's just quote, quote, a mild interference, we can call it mild cognitive impairment. What is the problem? That usually the working memory is the first one that goes off when people are having Alzheimer's disease. So since it's very common, the translation is that, oh, if I don't remember the name of my family members, I have Alzheimer's disease, which is true. And this is maybe the most common form of dementia. Yeah, but there are other forms that are equally present, obviously less common, but they are equally present, and you can have a diagnosis just with one domain less. The other question was the optimization. That is very important. Optimization is something that to work with your doctor. One thing that we are trying, I'm trying to, and we are trying here at Mayo, but I'm trying personally, is to customize, individualize very specific treatment for my patients. In other words, I need to know how long the medication lasts, how long does it take to kick in, what kind of diet is being used, what kind of dose seem to be having an effect, what kind of duration of the effect is. If there are some peak doses phenomena, like for example, dyskinesia or dystonia, once you tell your doctor all this information, he or she should be able to find the best that works for you. On the other hand, sometimes it's not easy. Sometimes it's an art that requires some time. And if your doctor doesn't spend too much time with you, it's very difficult to individualize this part. Especially, let me touch base again with early onset. If somebody's having a high profile job, and even if it's not a profile, somebody's working in an office and he or she is doing multiple things at the same time. Or somebody's an athlete and needs to run or needs to bike, the requirement of the medication are different according to what it is needed in the time. If I have a patient that runs marathon, I had to give more during the marathon, but it's something that we had to discuss. Okay, you know, let's anticipate the crash. Let's give you half more or one tablet more of Cinemet and so forth. Likewise, if somebody has we know, for example, it depends on the jobs clearly, but sometimes, you know, my mornings are always difficult. My mornings, I have plenty of things coming. In the afternoon, not so much. Or maybe I'm good, but in next week, I'm incredibly stressed because I have a presentation to give and I want to be doing a good job and so forth. Maybe the week prior, we had to find a way, talking to your doctor, to adjust the medication because maybe your body requires more. And then once the stressor, the sport activity, the event, you can go back to a more regular doses. But the entire question is that your doctor and yourself should not be afraid to optimize, to individualize the treatment according to your needs. I want to say something and then I'll stop. It's like diabetes, right? If I don't have diabetes, but if somebody has diabetes, right? And have high glucose level, the glucose comes up. Now we have ways to measure in real time, the level of glucose in the bloodstream. And then there are ways to give different amount of insulin according to the requirement of the time. We had to do the same, more or less, in Parkinson's disease. When there's more need, we can give more. Otherwise, we can give less.
Okay, so you is there a similar thing that you can do depending upon maybe a certain diet that someone has?
Yeah.
Like, let's say they're a vegan or they're, I don't know, just something. Do you do that?
Well,
Is there something that we can do that we can look out for or look to do to if we start to notice signs like this, right?
So that is a great point. Diet, it's something that is getting more and more important. And to be honest, it doesn't matter whether people are gluten-free, vegan, vegetarian, pescatarian, you name it, the list is endless. Or like me, that I eat I'm Italian, it's tough to be vegan in Italian, trust me. It's like,
I'm Italian, I hear you.
You are. It's kind of difficult. Say, you are Mr. Palizzi. So it's like,
Palizzi and Di Loretto is our.
It's kind of tough, you know. Say, oh, it's not working. But anyway, forget about it. Joke. One thing is for sure. One thing I try to do. There are a couple of things I recommend my patients. Number one, when we are forced to take medication very often, obviously we want to make sure that the gold standard is carbidopa-levodopa, right? We want to make sure that carbidopa-levodopa is given on an empty stomach. I cannot say this enough. Empty stomach means 1 hour before meals or 2 hours after meals. It's not possible at times. If you take the medication every 3 hours, it's going to be tough. So at the time, what I recommend an hypoproteic diet. I recommend having minimal breakfast, maybe with a coffee, no milk, or maybe delayed an hour to get a milk, having minimal lunch with maybe some carbohydrates, no more than that, and having the larger protein meal at night. However, especially in early onset Parkinson disease, there is a mounting amount of evidence, mostly in animals, that intermittent fasting seem to be working better. Intermittent fasting, you can see online, there's plenty of ways to do it. People are getting 24 hours without eating. I do it personally, I always did it. It's basically, I eat one big meal at night, and then I don't do breakfast. I maybe eat an apple at lunch, and that's it. That's intermittent fasting. Interesting, without getting too much philosophical, even the major religions, you know, we're talking about fasting, all of them. Major religion, I mean, I don't want to say minor religion or other, but Christian, Jews, Muslim, everybody's having a moment of fasting because it's good for your body. So we are not inventing anything new. But what we know is that in mice, intermittent fasting seems to be delaying the damage caused by the mitochondria hyperactivity. And in early onset Parkinson disease, the mitochondria, these organelles I was talking before, are maybe the most likely target of our disease. In other words, are the ones that are driving more than in late onset the energetic crisis leading to cell damage. So intermittent fasting is something that can impact this particular pathway, and it's something that can help quite a lot, I would say.
Tom, do you have any questions you want to? He's covered so much of what we were going to ask.
Oh, no, it's tough.
Yeah, exactly. A lot of the questions you've already answered, which has been great. I've learned so much already. I'm just amazed at how deep this has gone so quickly. So I really, really appreciate that.
Pleasure.
I think really what I think most people like me are going to want to know is I was diagnosed with early onset or young onset, whatever you want to call it. And does that impact my life worse in the future? I think you answered it earlier that there's no real evidence to support that, but
let me say this because it's very important.
Okay.
So I am talking about big numbers. I'm not talking about individual patients. So clearly everybody's different and there are exceptions in the big numbers. But if you look at the population, so we have been looking in the population living Southeast Minnesota. So the entire population working that lives around Olmsted County, we're able to follow them from the moment that they were born or they moved here to the moment they died. So we have 30, 40 years of observation of medical records that we review. So we have a very good snapshot on a population. The population is clearly white, Caucasian, Northern European heritage, so may not apply to everyone, but it can give us a snapshot. What we know is that a diagnosis of early onset Parkinson disease usually is more benign. What I mean is that it does not progress as fast as late onset Parkinson. The survival time I told you is 38 years from diagnosis, which, if your diagnosis at 45, 40 is still 78, 80. More or less is the life expectancy of our humans in this moment in the Western world. The important thing, say, okay, you're telling me about life expectancy, what about my quality of life? If I tell you that this is a little bit more benign, means that generally speaking, we don't see the same kind of decline that we see in later onset patients. Obviously they're older, there's aging process, there's major comorbidities that can put people down. One thing is important also, that it seems that the patient that have early onset Parkinson disease always respond to the medications. It's just a matter of adjusting them. And the complication, the very feared complications such as dyskinesia, for example, that are very feared, and there is a problem, right? You're concerned about that. They are present only in 12% of our patients, which is a small number. Again, it can happen, but it's smaller than what we see later on. And we are adjusting for the medication use. In other words, we are using the same amount, but we are changing. So what you will see in the future, I'm thinking that clearly it's better not to have any disease in life, right? Don't pick any disease. But early onset Parkinson disease, overall, given this big number trajectory, and again, there are exceptions to the rules, okay, is a disease that is way more benign than later onset, especially in some characteristics. I'm sorry, sir, if you're a woman, you have a better prognosis, generally speaking. If you started with tremor, if tremor is present from the beginning, seem to be a better prognostic signs. In other words, people are having a better prognosis than patients that do not have tremor at all. And there are mounting biological evidence to support why this is happening. It's not just random. There's a good reason why this can happen. So in addition, the third thing is that response to carbidopa levodopa. What I mean with that, there are some genetic forms. I'm sorry, my voice is getting down. There are some genetic forms that even a smidge of L-DOPA cause major side effects, dystonia, dyskinesia, and so forth. Unless we do the genes, we don't know whether somebody is having this mutation. But if you or any patients do not have this mutation, levodopa would always work. Okay, so I gave you a couple of things. Clearly, one of the things that I want to mention, and I know the Phinney Foundation is strong in that, and I am super strong in that, exercise, working out. All my patients, any age, but especially young, are working out.
Definitely.
And the young, to me, the youngs, I don't want them to work out like the elderly. I want the youngs to work out like the young. What means that? I want the young to do, okay, I like biking. Talk about biking, there is Phinney, right? I like biking. Well, excellent. You don't bike with people in their 80s. You bike people in their 30s or 40s or your age. Say, but I'm not there. Yes, okay, you're not there. You will make it there. And if you need more carbidopa levodopa, you're gonna take it. And you will be able to pick up. That is an important thing, like boxing. I love the Parkinson boxing clubs. They're fantastic. Somebody in the 30s, 40s, you want to do box, you do the regular boxing. You go to the regular boxing club, not to the Parkinson boxing club. You like to martial arts, go to grapple. I'm not kidding, grappling, Brazilian Jiu-Jitsu, those are fantastic activities because allow the proprioception to be constantly stimulated. Prevent falls, and falls is my biggest fear, okay? So, but doing the regular one, tell the trainer, hey, I have Parkinson's disease. So I mean, maybe I'm not the fastest, but still, you want to measure yourself with people at your age, not people in their 80s, when you're not relate to them. You're not relating at all. So that is something that I always say to my patients.
That's interesting. Also, so along those lines, somebody said often when they exercise really hard, like right after, they have increased brain fog. And then after they recover, they actually feel better with their non-motor symptoms and their motor symptoms. Is that common? And
Very common.
Brain fog, what's happening to make the brain fog? Is it just that you've kind of gone through your medicine, you've metabolized everything, or
likely there's a bioenergetic requirement that is higher. And so immediately there's a lack of dopamine or any other chemicals, but then the exercise helps the surge back on these particular chemicals. It's very common to say, you know, right after I'm exhausted, I'm fatigued, I'm wiped out, but I rest 5 minutes and I feel great. This is exactly what happens many times. And I'm not surprised to hear that indeed.
Yeah, that's definitely the case. And I think I do a lot of cycling. I run a pedaling for Parkinson's class 3 days a week. And again, I think the idea there is to push it, not just pedal. So there's
Correct.
There's some access to the exercise. Somebody posted a really interesting question here I just saw a minute ago about plasticity and the possibility of creating new pathways.
Absolutely. So it's kind of complex. I will try to cram it in a little amount. So we have some systems. Our system is the basal ganglia. The basal ganglia is a system that we have ever since we were born that is relevant to tell, to regulate, and to clean out the noise around a movement, around an action. And it's something that we developed ever since we were young. So in other words, if I do this movement, I'm very precise in doing it. I'm not doing everything else. My basal ganglia is removing everything else to allow me to do this movement very precisely. And ever since I was a little kid, I was born, I developed this system. But it's interesting because there's a big cortex, and the basal ganglia are little tiny nuclei that did not evolve as much as the cortex. So everything goes in this little narrow path, which is very difficult to manage. What we want to do when we are getting older, but at any age, we want to make sure that this noise surrounding the basal ganglia that is trying to do that is removed. And we want to make sure that the basal ganglia are getting more information about the noise from somewhere else. So that is why it's crucial to build new pathway. This is crucial using what? The plasticity of the brain is something that happens anytime. Clearly, as we get older, it's different. But there are some movements, some activity, including movements, that can help dramatically increasing the plasticity, increasing the basal ganglia activity. And there are some chemicals that are produced during the exercise, the famous BDNF, brain-derived nerve factor, that increase dramatically and help restoring new cells and sprouting new connection. Clearly, let's say I still say grapple just because it's what I do for fun. It's my side job. So I teach martial arts as a side job. So let's say you do martial arts and you never did martial arts, but you like to do it. That is a great opportunity because then your body would use complete different motor pathways, areas that you never used before. So that would improve the quality of your movement regularly, just because you're giving more information coming from different sources. So it is very, very important. And the plasticity is something that I am really keen in to do it. That's why I say my patient to exercise. However, evolutionary, we have a problem. The evolution of the basal ganglia I mentioned is being delayed. We're about 500,000 years behind compared to the rest of the cortex. I'm not kidding. So there's a fish called lamprey that is the one that diverged from us, but all the animals and monkeys and all the vertebrate are having the same basal ganglia structure. It's very small. Finally, some monkeys now, they seem to have something called hyperdirect pathway that goes from the basal ganglia straight to the frontal lobe without getting a different additional stations. And it seems that humans have that. But the idea is that is a newer, yet young, yet to be developed pathway that can help compensate some of the problems that we are having with movements later in life, like Parkinson's disease. So it's very complex, but it's fascinating, to be honest.
Let's see. So a couple of people are asking just the relationship. Is there any, does DBS can do anything around dementia symptoms, executive function, anything like that?
Well, historically, the selection of the patients, the patient that have memory loss, were excluded for deep brain stimulations. So in other words, if somebody was having some in the testing, so to do DBS, you have to go to a center, they do a number of tests, including memory loss testing and a full hour memory test. If in the memory test, patients are not doing that well, there's always a risk that the deep brain stimulation can make things worse a little bit in terms of memory. So the short answer is that deep brain stimulators should not have any effect on executive function. If anything, they can make things a little bit worse. There were some studies years ago done from some of the pioneers on the DBS field coming from Canada, Dr. Lozano and his team from Toronto. They were studying deep brain stimulation in Alzheimer. They had a number of cases of Alzheimer, and they were stimulating some areas of the brain that were allegedly involved in memory, and they did not see any particular improvement. But there's a good reason why, because memory is everywhere. The engram of memory are stored everywhere, and there's different kind of memory. So stimulating one area doesn't necessarily mean that you will improve. Again, there are some patients that report some improvement because of the dopaminergic requirement that has changed. But remember, there are some patients with deep brain stimulation that even though from a motor standpoint, from a tremor, rigidity standpoint, they do not require carbidopa-levodopa. They do require it because they have fluctuations of the non-motor symptoms, like anxiety, depression, or memory loss. So just to tell you that the DBS is really focusing so far on the motor aspect of the problem, not necessarily to the non-motor one.
I was going to say I had another question for you, but I forgot.
Yes.
No, I'm just kidding. When I was diagnosed years ago, 13 years ago, shortly after that, maybe 10 years ago, I said to my doctor something along the lines of that I'm mostly worried about losing my mentality, my cognitive capability than I am the mobility capability. And she jumped on that. She goes, well, let's get you tested let's have a psych test done to see how you perform. That scared me to death. But what I did notice from that is it really helped me establish a benchmark where I was, so I had something to compare my cognitive ability later in life. And so what are your feelings on that?
I think it's good. Having a baseline, you say having a 2 to 4 hour memory test would be good, but also having a paper and pencil test done 10 minutes in the office of your physician can be very important, even earlier on. And if, as you say, I'm worried that with time, things can get worse, having a baseline a few years prior can help see if you have a decline. There are only few things that we have to consider. Obviously, as you get older, you're missing some of these points. As you get older, 20, 30 years later, your memory test has to be adjusted for the age that you have. And usually they are, because the tests are standardized. What at times I do, and this is the behavioral neurologist that comes in, I'm also a behavioral neurologist, so that's the point. Sometimes, as you know, you say, I was scared to death. Clearly, I'm pretty sure that when you did the test, you didn't feel the best. At the end, you say, oh my God, I fluke it. Oh my God, I'm so anxious, it's going to be a problem, which is true. That makes a world of a difference. Anxiety, depression, the mood, the state of mood, maybe the morning you fought with your friend or with your wife, something that can interact and interface with our performance. Sometimes I'm ordering, when I'm worried about memory test, a PET scan of the brain. The brain PET scan, not DAT scan, PET scan is an objective measure of how the brain is using glucose and is heavily used in behavioral neurology to see the different patterns of memory disorders. So that would be something that even if you're upset or if you're anxious or if you have a panic attack in that moment, it should not be affected. So I say, I agree with you, getting a baseline is important, either a paper and pencil test, and if the paper and pencil test done by your physician is down, a big test 2 to 4 hours. But even if there are some issues because patients are anxious, upset, or they don't like it, PET scan can be a very good alternative, I would say.
Great.
That's exactly what happened to me. I walked in the room to have my test, and beads of sweat were coming off my forehead. And the doctor says, "Are you okay? Are you having a heart attack or something?" I was like, "No." He said, "Look, I'll give you a half hour to settle down, then we'll get to your test." And fortunately, I was able to get through it okay. So,
but that is a real problem. Huh? That is a real problem. A real problem indeed.
Good. Well, I know that I could talk to you for another 3 hours. And I know a lot of people on here have said this is the best YOPD discussion we've ever had.
Very kind.
And so we're really happy because Dr. Savica is actually going to be joining us for our YOPD, the Victory Summit event. That'll be happening at the end of June. So look out for that. And yeah, so we'll have more opportunities to ask you lots of questions. Dr. Savica, thank you so much for being here today. Thank you, Tom.
Pleasure.
Tag teaming with me, and we will get everybody the recordings and everything that you need. And I'm so grateful for you to be here.
Here.
It's been a pleasure for real. Thanks for having me.
Thank you.
Bye, everybody.
Bye-bye.